Imagine spending like 2,500 pounds going through weeks of surgical recovery wearing these incredibly uncomfortable compression garments, only to find out that up to 50% of the material you just had injected into your body is going to, well, completely vanish in a matter of months.
Right, yeah. It's a completely startling statistic to encounter, especially if you aren't prepared for it.
I mean, it's wild, but that is the biological reality of gynecological fat transfer, which is one of the more intense options for a procedure that is quietly but massively surging in popularity right now.
Exactly. And biologically speaking, it actually makes perfect sense when you understand how grafted tissue fights to survive in a new environment. And I think that tension, that gap between what we expect from a cosmetic procedure and what our bodies actually do is exactly why this topic requires such a rigorous look.
Yeah, absolutely. And that is exactly our mission for today's Dep Dive. So, welcome. If you are joining us, we know you are someone who values being thoroughly, completely informed before making big medical decisions.
Which is so important here.
It really is. Today, we are taking a highly specific, comprehensive look at preparing for a labial filler appointment. We've got this massive stack of sources today covering everything from clinical medical guidelines and aesthetic clinic brochures to some really sobering safety campaigns from BAPS, which is the British Association of Aesthetic Plastic Surgeons.
Some really vital data in there.
For sure. So the goal here is to completely demystify what is colloquially called the labial puff. We're going to separate the marketing fluff from the biological reality, compare the actual mechanisms of the different injectables, and most importantly, arm you with a rigorous survival guide for navigating what is, frankly, a terrifyingly unregulated market. Okay, let's unpack this.
I think the best place to anchor this conversation is really by setting a firm baseline right out of the gate.
Right.
Because while these procedures are rapidly growing and they do offer profound physical benefits, they are fundamentally medical interventions.
Not just a spa treatment.
Exactly. They require a deep, highly nuanced understanding of pelvic anatomy, a clear-eyed view of the risks, and a truly qualified practitioner. I mean, this isn't a quick beauty tweak you just go and do on your lunch break. It is a clinical procedure actively altering your tissue architecture.
Okay, wait. Altering tissue architecture, because that sounds incredibly intense. Are we just talking about like a glorified oversized lip filler here, or is this fundamentally a different kind of medicine?
It's quite different in its application and necessity.
Because if we are going to look at how to fix this, we really need to understand the biological problem first. Like what is actually happening at a cellular level that prompts a woman to seek out this specific kind of filler in the first place?
Well, it really all comes down to labial laxity and volume loss in the labia majora, so the outer folds of the vulva. And there are a few primary biological culprits for this structural collapse.
Like just standard aging?
Yeah, the first is just the natural aging process. The tissue down there relies on this very dense matrix of collagen and elastin to maintain its bounce and structure. And as we age, your body's production of those proteins just plummets.
Right, the whole system slows down.
Exactly. The existing scaffolding basically begins to degrade, which leads to this overall deflation.
But it's not just a slow, gradual aging process, is it? Because the sources talk about how physical trauma plays a massive role here, too, particularly childbirth.
Oh, absolutely. The immense physical stretching and trauma of childbirth can literally tear that collagen matrix. So the tissue loses its elasticity permanently. It simply cannot snap back to its original state after that kind of trauma. And then on top of that, you introduce hormonal shifts.
Like menopause.
Right, particularly the onset of menopause.
I want to dig into that for a second because I don't think people realize, how drastically hormones dictate actual structural integrity. How does a drop in estrogen actually change the physical tissue?
Well, estrogen isn't just a reproductive hormone. It is a vital signaling molecule.
Okay, signaling what exactly?
It basically tells the mucosal tissue in the pelvic region to stay thick, plump, and hydrated. So when estrogen levels plummet during menopause, those signals just stop.
Wow.
The result is a condition called vulvovaginal atrophy. The skin literally thins out, it loses its natural moisture barrier, and it becomes incredibly fragile.
That sounds awful. And on top of aging and trauma and hormones, the sources highlighted this very modern phenomenon driving this procedure, which is rapid, massive weight loss. Like, we are seeing the term Ozempic vulva popping up everywhere right now.
Yes. So with the widespread use of GLP-1 agonists, the body sheds fat indiscriminately, It doesn't just pull from your abdomen or your thighs, it pulls from everywhere,
Including down there.
including the protective fat pad located inside the labia majora. And when you lose that localized volume so rapidly, the overlying skin simply doesn't have the biological time to retract.
The elasticity just can't keep up.
Right. It can't keep up with the fat loss, which results in severe sudden laxity.
This is the exact point where I think the marketing completely misses the mark, because it positions this volume loss as this purely cosmetic annoyance. But the labia majora aren't just aesthetic features.
Not at all.
They serve a highly functional physical purpose. Think of them like a biological shock absorber for the body. They are a protective cushion for the highly sensitive internal mucosal structures. When that padding wears thin, you aren't just dealing with wrinkles, you are dealing with intense friction. So is this just a cosmetic trend, or is it fundamentally about restoring function and comfort?
If we connect this to the bigger picture, the narrative that this is purely an aesthetic vanity project is completely backwards for a vast majority of patients.
Right.
When those shock absorbers deflate, patients suffer from what the medical literature calls exposure symptoms.
Which means what, practically speaking, for someone's day-to-day life?
It means chronic dryness and severe irritation.
Yeah.
It means agonizing chafing when trying to exercise, ride a bike, or even just wearing fitted clothing like leggings.
Oh, man. That's brutal.
It is. The friction causes these micro tears in the fragile tissue. And this frequently leads to dyspareunia, which is intensely painful sexual intercourse. And because that physical barrier is compromised, patients become highly susceptible to recurrent infections.
Because the shield is basically gone.
Exactly. So yes, there is a cosmetic improvement that offers a very valid boost in self-esteem. But for many women, the aesthetic change is entirely secondary to the return of physical comfort and the restoration of sexual confidence.
Okay, so if the biological problem is that the structural shock absorbers have deflated, how do we reinflate them? Based on our sources, we're really looking at three main biological interventions here: hyaluronic acid, calcium hydroxylapatite, and fat transfer. Let's start with the most common one, which is hyaluronic acid, or HA. What is it actually doing under the skin?
So hyaluronic acid is fascinating because it is a linear polymer that already exists naturally in your body's connective tissues.
When you say linear polymer, what does that actually look like microscopically? What is it?
Think of it like a really long microscopic chain of sugar molecules.
Okay.
And its primary superpower is its ability to bind to water. In fact, it can hold up to 1,000 times its own weight in water.
1,000 times? That's insane.
It really is. So when specific brands of HA, like Deserial, which is formulated exclusively for women's intimate health, or Novia Intense Rose, when those are injected, those long sugar chains create a dense, compression-resistant gel.
So it is essentially acting like a microscopic sponge, just drawing in surrounding moisture to physically prop up the tissue.
Exactly. It plumps the tissue instantly, but it also deeply hydrates the surrounding cells from the inside out.
And how long does that sponge hold up?
The effects typically last 12 to 18 months as the body's natural enzymes gradually metabolize and break down that sugar chain.
And a major selling point here is reversibility, right? Because if there is a complication or if the patient just hates the result, you can inject an enzyme called hyaluronidase, which, as I understand it, acts like molecular scissors.
Right? It instantly snips those sugar chains apart and dissolves the filler almost immediately. So HA acts as an excellent low-barrier entry point. But, as we said, it is temporary.
Right.
If a patient wants something longer-lasting, the next intervention is calcium hydroxylapatite, or KT, which is commonly known by the brand name Redase.
Okay, so how does calcium act differently than the hydrating sugar sponge?
So KT products contain microscopic calcium particles suspended in a water-based gel. When it's initially injected, the gel provides immediate volume, very similar to HA. But the real mechanism kicks in over the next few months.
What happens then?
The body detects these tiny calcium microspheres, and instead of just sitting there, they act as a rigid scaffolding. They actively stimulate your body's own fibroblasts.
Fibroblasts being the cellular construction workers that build structural proteins, right?
Correct. The fibroblasts climb onto this calcium scaffolding, and they start pumping out brand new collagen.
Oh, wow. So it's building new tissue.
Exactly. So while the initial gel carrier is absorbed by the body, it is eventually replaced by a dense network of your own biological collagen. And because it is actively generating new structural tissue, the results last significantly longer, up to 2 years.
But wait, if it's stimulating my own natural collagen, why does it eventually wear off at all? Shouldn't that new collagen just, stay there?
It does stay there, but you are still fighting the continuous biological clock of aging and estrogen depletion we talked about earlier.
Ah, right, the degradation.
Yeah, your body is constantly breaking down collagen faster than it can produce it as you age. So eventually, even that newly generated tissue degrades. And crucially, unlike HA is not reversible. You cannot dissolve it with an enzyme. You simply have to wait for the body to naturally metabolize it over time.
Which naturally leads us to the most extreme biological intervention out of the three: gynecological fat transfer. Now, this is a full surgical alternative. It involves microliposuction, usually harvesting fat from the abdomen or the thighs. The fat is purified in a centrifuge and then injected into the labia. But this goes back to that wild statistic we opened the show with. You pay thousands of pounds. I think the source is set around 2,500. You endure liposuction recovery, and then 30 to 50% of that transferred fat just dies off in the first few months. Why is the failure rate so incredibly high?
It all comes down to blood supply.
Okay.
When you move fat cells from the abdomen to the labia, you are completely severing them from their life support system.
Oh, I see.
The newly injected fat has to rapidly stimulate new blood vessels in the labia to feed it oxygen and nutrients.
Yeah.
This is a process called angiogenesis.
And if it doesn't hook up fast enough?
The cells that fail to establish that new blood supply simply die, and they are reabsorbed by the body.
So a surgeon essentially has to guess the survival rate and intentionally overfill the area knowing half of it will vanish. That sounds incredibly imprecise.
It is a known biological variable that requires immense surgical skill to balance. But, and this is the big but, the fat, that does survive the transfer and establishes that new vascular connection. That tissue is permanent.
It sees forever.
Right. It becomes a living, breathing part of the local anatomy, behaving just like the rest of the fat in your body.
And the real magic here isn't just permanent volume, is it? Because the medical literature places massive emphasis on something called the stromal vascular fraction within that surviving fat. What is that, and why does it matter so much?
The stromal vascular fraction is this incredibly rich, dense mixture of cells hidden within the fat tissue itself. This includes powerful mesenchymal stem cells and growth factors.
Oh, so it's not just fat.
Exactly.
Yeah.
When you transfer this fat, you aren't just moving passive inert padding. You are moving an active biological repair kit,
So it is actually healing the surrounding tissue.
profoundly healing it. Those stem cells and growth factors improve the overall health of the local environment. They trigger the formation of new capillary networks. They drastically increase blood flow.
Wow.
And they can even soften and remodel thick, painful scar tissue left over from things like episiotomies, childbirth tears, or previous radiotherapy. They fundamentally rejuvenate the cellular quality of the skin itself.
Okay, here's where it gets really interesting, though. If fat transfer offers a permanent result, uses your own body's natural material, and comes with a built-in stem cell repair kit, why on earth would anyone choose a temporary HA sponge that requires a touch-up every single year?
It is the ultimate trade-off between convenience and biological commitment.
How so?
Well, an HA filler appointment takes 15 to 30 minutes. It is a non-surgical procedure done under local anesthetic with virtually zero downtime.
You literally just drive yourself home.
Exactly. It is a brilliant test run. Fat transfer, on the other hand, is a surgical commitment. You have to recover from the liposuction donor sites, you have to manage a complex inflammatory healing process, and you have to accept permanent results.
Right, if you don't like it, you can't just dissolve it.
Exactly. Fat transfer is generally suited for patients needing profound structural repair or scar remodeling, whereas HA is the ideal reversible entry point.
That makes perfect sense. So whether you opt for a temporary sugar sponge or a permanent biological repair kit, the single most critical variable in this entire process isn't actually the material, it is the person holding the syringe.
100%.
And looking at the data from the British Association of Aesthetic Plastic Surgeons, BAPS, the landscape out there is, frankly, terrifying.
The statistics are a massive red flag for anyone considering this procedure. When looking at complications specifically from body contouring fillers, almost a fifth of surgeons, 19%, reported seeing between 1 and 3 patients in a single year just to fix botched permanent filler procedures.
19%. And nearly 1 in 10 surgeons had to intervene for a staggering 10 to 12 patients with severe tissue-threatening complications. I mean, that isn't just an occasional mistake. That is a systemic failure. Why is there so much medical repair work happening for a procedure that is marketed as a routine lunchtime tweak?
The root cause, particularly in the UK, is a massive gaping hole in regulatory law. Currently, dermal fillers are classified as medical devices, not prescription medicines.
Wait, how does a gel injected into the body get classified the same way as, like, a pair of crutches or a pacemaker? That makes no sense.
It is entirely a historical loophole. Pacemakers are medical devices, yes, but they are surgically implanted by specialized cardiologists in
Oh.
a hospital.
Right.
Fillers slipped into that exact same device category, but without the mandate that a doctor must administer them. This means that, legally, a non-medical practitioner, like a beauty therapist, with zero clinical background, zero anatomical training, and zero ability to write a prescription, can literally just purchase these substances online and inject them into complex human tissue.
It's like buying a parachute on clearance from an unverified seller on the internet. Like, sure, you might save a few pounds, but when it fails, the consequences are catastrophic. It is just not worth the risk.
Not at all.
So how do you actually defend yourself? If a beauty therapist can legally set up shop and offer this, what is your survival guide as the patient? The British College of Aesthetic Medicine, BSAM, and the NHS actually have a vet it before you get it framework. Let's adapt this into an actual defense strategy for you, the listener. What is the absolute first thing someone should demand to see before even sitting in the chair?
Credentials. Unquestionably. You must independently verify that the practitioner is registered with a recognized statutory medical body.
So what does that look like in the UK?
That means the GMC for doctors, the GDC for dentists, the NMC for nurses, or the GPHC for prescribing pharmacists. If they show you a certificate from a 2-day weekend training course at a local hotel, walk out the door.
Yeah, that is not proof of medical competency. Okay, so you have verified they are a doctor or a nurse. What about the actual substance going into your body?
You demand to see the packaging.
Yeah.
You need to know exactly what brand of filler is being used. Is it FDA approved or CE marked for safety? And this is where the economics become a major warning sign.
Right, the pricing.
Avoid heavily discounted treatments. High quality, safe, clinically tested filler has a set market cost. If a clinic is offering a massive discount, it is a glaring red flag that they are purchasing unregulated, black market, or counterfeit goods.
Next on the checklist is specific experience. Because it is not enough that they have injected lips or cheeks for a decade, right?
No, not at all. The anatomy of the pelvic region, the vascular networks, the nerves, the mucosal tissue, it is incredibly complex and entirely different from the face. You have to explicitly ask, how many specific labial procedures have it performed?
Right. And finally, the most critical question on the NHS checklist. Emergency protocols. Do they have hyaluronidase, the dissolving enzyme we mentioned, physically drawn up or immediately on hand in the clinic? Do they have a clear, rehearsed clinical pathway if something goes wrong?
This raises an important question. Why does a medical background actually matter if the injection itself is mechanically just, pushing a plunger?
Yeah, why does it?
Because pushing the plunger is only 5% of the job. A practitioner needs deep anatomical knowledge to navigate around critical, hidden blood vessels. They need the diagnostic training to spot the microscopic early signs of a deep tissue infection. And crucially, they need the legal medical authority to prescribe antibiotics or administer high-dose dissolvers instantly if a complication arises.
Which a beauty therapist cannot do.
A beauty therapist cannot legally write a prescription to save your dying tissue when things go south. As the APS safety guide bluntly states, if they tell you the procedure is 100% risk-free, run.
Run, literally. All right, so let's say you have thoroughly vetted a highly qualified medical professional. You are sitting in a sterile clinical environment and you are ready. What actually happens biologically during the procedure, and what are the specific risks you need to monitor for when you go home?
The procedure itself is relatively swift, usually 15 to 30 minutes. The area is meticulously sterilized to prevent surface bacteria from being pushed deep into the tissue.
Naturally.
A topical numbing cream is applied, followed by a local anesthetic injection, usually lidocaine, to ensure complete comfort. Then, the practitioner uses a fine cannula to introduce the filler deep into the subcutaneous tissue.
Wait, why a cannula instead of just a standard needle?
A cannula is a flexible tube with a blunt, rounded tip. Unlike a sharp needle, which slices indiscriminately through tissue and blood vessels, causing immense bruising and trauma.
Yikes.
A blunt cannula gently pushes blood vessels aside as it glides under the skin. It's much safer. Once the gel is placed, the practitioner gently massages it to mold it into a natural functional contour.
And I imagine you will experience some immediate side effects from that, right? Like swelling, bruising, and tenderness that lasts for a few days.
Yes, but that is just your immune system reacting to the physical intrusion of the cannula and the sudden expansion of volume.
Right. But we have to talk about the severe risks. The one that stands out in the sources as an absolute nightmare scenario is vascular occlusion.
Vascular occlusion is the most terrifying complication in aesthetic medicine.
What exactly causes it?
It occurs when the filler is inadvertently injected directly inside a blood vessel, creating a plug. Or when too much filler is injected too quickly, acting like a tourniquet and compressing a vessel from the outside.
Oh, wow.
In either scenario, the arterial blood supply to the skin and surrounding tissue is completely cut off.
What does that actually look and feel like in real time? Like, how would a patient know it's happening to them?
The hallmark symptom is intense, disproportionate throbbing pain that extends way beyond the injection site. Visually, you see a phenomenon called blanching. The skin turns stark white, pale, or mottled and blotchy because it is being completely starved of oxygen-rich blood. This is a severe, ticking clock medical emergency. If the area isn't immediately flooded with hyaluronidase to dissolve the blockage and restore blood flow, the tissue will begin to die.
That is horrifying.
It's a catastrophic process called necrosis.
So that's the absolute worst case immediate scenario. Aside from vascular occlusion, there are longer-term risks too, like delayed infections or immune reactions. Sometimes, weeks or even months later, your immune system suddenly decides it just doesn't tolerate the filler, leading to granulomas. These are like hard, inflamed, painful nodules trapped under the skin.
Yes.
There's also the risk of migration, where the filler shifts from the labia majora into the labia minora or other unintended areas.
And we must make a very explicit warning here about permanent synthetic fillers. The medical consensus strongly discourages them in this area.
Because you can't dissolve them.
Exactly. Unlike fat transfer, which is natural living tissue, permanent synthetic polymers act as foreign bodies forever. The immune system constantly attacks them, causing excessive, hard scar tissue capsules to form around the implant.
And if that happens, how do you get rid of it?
When complications arise with permanent synthetic fillers, you cannot dissolve them. They require invasive surgical excision, meaning a surgeon literally has to cut the hardened plastic material out of your delicate mucosal tissue.
Okay, that is terrifying. So what does this all mean? It means even if the procedure only takes 20 minutes, the biological integration of that material takes weeks. The aftercare is just as critical as the clinical injection itself.
Precisely. The biological guidelines are incredibly strict. You must avoid heat-inducing activities like saunas, hot baths, or heavy exercise for 24 to 48 hours to prevent exacerbating the inflammatory swelling.
No hot yoga.
No hot yoga. No alcohol either, which acts as a vasodilator, thinning the blood and severely increasing bruising. And most importantly, absolute pelvic rest for 7 to 14 days.
Which means no sexual intercourse, no cycling, no horse riding, and no tight clothing.
Right. The filler is malleable at first. It needs time to cross-link and integrate into the tissue matrix without being physically displaced by friction or pressure.
Which perfectly illustrates why the consultation phase isn't just a friendly chat, You have to disclose your entire medical history.
Yeah.
If you are taking NSAIDs like ibuprofen, your blood is thin and your bleeding risk skyrockets.
Exactly.
If you have an autoimmune condition, your risk for a delayed granuloma response is massively amplified. Previous pelvic radiation completely alters the vascular safety profile of the tissue. You absolutely cannot withhold information from your practitioner.
It is a perfect example of why thorough research, extreme vetting, and a deep understanding of your own unique biology are the only shield you have in a market that, unfortunately, often prioritizes rapid cosmetic fixes over rigorous medical care.
Taking the time to understand the cellular mechanisms, why the tissue thins out, how a linear polymer binds water, the severe realities of vascular necrosis that isn't just preparation for an appointment, it is the ultimate form of self-defense.
Absolutely.
To you listening, if you are sitting in a clinic and they offer you a heavy discount or promise a risk-free lunchtime fix, you now have the biological knowledge to recognize the red flags and walk away. That level of preparation is the ultimate form of self-care.
What's fascinating here, if we look at where the science is actually heading, is that we are currently witnessing a massive paradigm shift in aesthetic and functional medicine. We briefly touched on the regenerative properties of the stromal vascular fraction and fat transfer earlier.
Right, the stem cells.
Yeah. We are moving entirely away from the outdated model of merely filling a space like pumping cosmetic spackle into a structural crack.
The goal is no longer just brute force inflation.
Exactly. The future is pure biostimulation. Between platelet-rich plasma, stem cells, and targeted peptides, we are learning how to actively trick the body's own cells into reversing the biological clock. We are prompting the local tissue to grow entirely new, youthful, healthy vascular networks on its own.
That's incredible.
It really makes you wonder, in 10 years, will we even be injecting synthetic gel fillers at all? Or will all cosmetic procedures simply be a matter of writing a biological code, instructing our own bodies to heal and rebuild themselves from the inside out?
That is a wild thought to leave on. The era of synthetic spackle might literally be coming to an end. So the next time you are evaluating a medical procedure, remember the blueprints for your own biology, vet the practitioner, respect the complex anatomy, and never settle for a bargain bin parachute. We'll catch you on the next deep dive.